The foot, acute and traumatic injuries. The foot is highly vulnerable to a variety of injuries. The forces that the foot encounters can result in acute traumatic or overuse injuries. Injuries can best be prevented by selecting appropriate footwear, correcting biomechanical structural deficiencies through orthotics, or paying attention to personal hygiene. Selecting appropriate footwear. When selecting appropriate footwear, there are multiple options available. Footwear should be appropriate for the existing structural variations in an individual's foot. The midsole of the shoe helps control motion along the medial aspect of the foot or the inside of the foot. Other aspects of a shoe that may impact the performance of a shoe are outsole contour and composition, lacing systems, and forefoot wedges. The basic form upon which a shoe is built is called the last. The slip-lasted shoe or moccasin style is very flexible. A board-lasted shoe provides a firm, inflexible base. A combination-lasted shoe provides rear foot stability and forefoot mobility. The shape of the last should be considered. Straight last curve versus a curve-lasted. Midsole designs can help control motion along the medial aspect of the foot. The three pictures on the left side of the screen are the three types of shoe lasts. A is a slip last shoe that creates a sock-like layer that's stitched around the last that makes it flexible. B is a board-lasted shoe that has a fiberboard layer stapled or glued to the last. C is a combination-lasted shoe that is boarded behind and slip-lasted in the front. Different types of shoes. For pronators, a rigid shoe is recommended, while supinators require a more flexible footwear with increased cushioning. Heel counters are often used to control motion in the rear foot. Other aspects of a shoe that may impact the performance of a shoe are the outsole contour and composition, lacing, and forefoot wedges. Preventing foot injuries. Orthotics are used to help correct biomechanical problems in the foot. They can be constructed out of plastic, rubber, cork, or even leather. They can be prefabricated or custom fitted. To prevent injury, foot hygiene is also important, such as keeping toenails trimmed correctly, shaving down excessive calluses, keeping the feet clean, wearing clean and correctly fitting socks and shoes, and keeping the feet as dry as possible to prevent the development of athlete's foot. Foot assessment. In any injury assessment, it begins with history, then an observation, palpations, and special tests. We follow the HOPS protocol, HOPS, history, observation, palpation, special test, HOPS. You should start with all generic foot history questions and then ask questions specific to the foot, including the location of pain in the heel, toes, and even arches, training surfaces or changes in footwear, and if the footwear causes or increases discomfort. Some observations for the foot include if the patient favors a foot, walks with a limp, or is unable to bear weight. Other questions may include, does the foot change color when weight bearing? Is there pes planus or pes cavus? This has to do with a high arch or a low arch. Pes planus is flat-footed, while pes cavus is considered a high arch. We'll start talking about some injuries. For all injuries, we will examine the etiology or definition, the signs and symptoms of the injury, and the immediate management strategies. The first injury we'll start with is a fractured talus. A fractured talus is a fracture to the talar bone, which is a tarsal bone in the rear foot. This occurs either laterally from a severe inversion in dorsiflexion force or medially from an inversion in plantar flexion force with tibial external rotation. Signs and symptoms of a talar fracture include history of repeated ankle trauma, pain with full weight bearing, intermittent swelling, catching or snapping, and the talar dome is tender upon palpation or touching. The management of a talar fracture requires rehabilitation to focus on strengthening and gaining full range of motion. If conservative treatment is unsuccessful, surgery may be required. Fractures to the calcaneus. The calcaneus or heel bone becomes injured or fractured from a jump or a fall from a height, and often results in an avulsion fracture anteriorly and posteriorly. An avulsion is where part of the tendon breaks off part of the bone. An anterior avulsion fracture can be misdiagnosed as tendinitis of the posterior tibialis muscle. Signs and symptoms of a calcaneal fracture include immediate swelling, pain, and an inability to bear weight. There is usually minimal deformity unless a comminuted fracture, which means that the fracture breaks into multiple parts, is suspected. The management of a calcaneal tarsal fracture should include the immediate referral for x-rays. For non-displaced fractures, immobilization and early range of motion exercises are warranted when pain and swelling subside. A heel contusion. A heel contusion is a heel bruise caused by sudden starts, stops, or changes in direction, or irritation to the fat pad that overlies the calcaneal bone on the heel. The patient will often complain of pain on the lateral aspect of the foot due to heel strike patterns. Signs and symptoms include severe pain in the heel and an inability to withstand the stress of weight bearing. Often there is warmth or redness that occur over the tender area. To manage a heel contusion, reduce weight bearing activity through the use of crutches or a cane. Typically, we do this for approximately 24 hours and utilize NSAIDs, known as non-steroidal anti-inflammatory drugs. These are often over-the-counter medications such as ibuprofen. Patients can resume activity with the help of a heel cup or a donut pad after the pain has subsided. An individual should make sure that they wear shock-absorbing shoes and correctly fitting socks to help pad the area. A Lisfranc injury is a tarsometatarsal fracture or dislocation. A Lisfranc fracture occurs when the foot is already plantar flexed and the rear foot is locked, resulting in dorsal displacement of the proximal end of the metatarsals. Lisfranc fractures are often found in car accident victims, runners, and military personnel. Signs and symptoms include pain and an inability to bear weight, swelling, and tenderness localized to the dorsum of the foot or the top of the foot. Possible metatarsal fractures and sprains of the fourth and fifth proximal metatarsals can happen. The key to management of a Lisfranc fracture is the recognition and referral, realignment, and maintaining stability of the injury. A Lisfranc injury generally requires a surgical procedure called an open reduction with fixation. This is where they cut the individual open and they stabilize the area with a pin or plate or screw to help fixate the area and not allow it to move. Complications include other foot conditions and potential long-term disability for the individual. A Jones fracture is a fracture of the metatarsal caused by inversion and plantar flexion, or by being stepped on or repetitive stress. The most common site of a Jones fracture is at the base of the fifth metatarsal. Signs and symptoms are immediate swelling with pain over the fifth metatarsal. There is a high non-union rate, which means that the course of healing is unpredictable and may not fully heal. The management of a Jones fracture is controversial. Often it is recommended that patients be on crutches with no immobilization and gradually progressing to weight bearing as pain subsides. This can allow patients to return to activity in as early as 6 weeks. If a non-union injury occurs, surgical intervention with internal fixation may be required. Turf toe is a hyperextension of the great toe. The hyperextension of the big toe injury results in a sprain of the first metatarsal phalangeal joint and may be the result of a single or repetitive trauma. Signs and symptoms include pain and swelling, which increases during the push off in walking, running, and jumping. To manage, patients should increase the rigidity of the forefoot region of the shoe. Tape the toe to prevent dorsiflexion or plantar flexion. Ice and ultrasound can help, and rest is recommended. Even if patients are pain free, they are discouraged from returning to activity too early to allow the healing process to occur. Toe fractures or dislocations. Toe fractures can occur when an individual kicks an object, stubs their toe, or their toes are stepped on. Dislocations are less common than fractures in the toes. Signs and symptoms include immediate and intense pain, and in the case of dislocation, an obvious deformity is typically seen. If a dislocation is suspected, it would need to be reduced by a physician, so refer that individual for appropriate care. Casting may occur with a great toe or multiple toe fractures. Buddy taping, as is seen on the screen, can be utilized for single toe fractures. Buddy taping in most cases is generally sufficient to care for a fracture. Subunguinal hematoma. A subunguinal hematoma is blood underneath the nail bed of the toe. It is typically the result of direct pressure, dropping an object on the toe, or kicking another object. This can also be from repetitive shearing forces on the toenail. Dancers and runners often end up with subunguinal hematomas. Signs and symptoms are the hallmark accumulation of blood underneath the nail. They are likely to produce extreme pain, and ultimately, the individual is likely to lose the nail. To manage the condition, apply an ice pack immediately and try to have the pressure relieved within 12 to 24 hours. This is typically done through using a drill or a heated tool device to go through the nail. The important thing is that these tools must be sterile to prevent infection, so it is recommended that this is done in a medical office.